Hi everyone, my name is Dr. Fahad Ismail and I'm here to deliver the lecture on somatosensory system. This is a two-part lecture covering both the transduction of touch and pain sensation. This slide just shows you an overview of what we will be covering in the first part of the lecture. Firstly, we will be going through the basic introduction of the sensation, then go through the receptors that are responsible for transducing the signal, then move on to the different pathways that it goes through and how it reaches the cortex. Finally, we will also touch upon the concept of somatosensory plasticity and diseases associated with the somatic sensory system. Just to give you a bit of a background, the somatosensory system is an important part of our basic senses. In my opinion, this system is easily overlooked since we are used to feeling our surroundings and we do take this for granted. As we sit in our chairs, fiddle our pens, rub our chins, or even hold our loved ones, we activate the processes involved in the somatosensory system. By definition, it allows us to feel, ache, and chill. The somatosensory system is different from other systems in the body, as it has receptors that are broadly distributed in the body. Furthermore, the receptors also have the ability to respond to many kinds of stimuli, whether these are changes in temperature, feeling the sound waves, and of course, the onset of a physical touch. The skin is divided into two types. You have the hairy skin or the glabrous skin. The best way to exemplify this is by looking at your hand. If you're looking at your palms, you can see an example of glabrous skin, which doesn't have any embedded hair follicles within the skin. If you look at the back of the palms, you can see an example of a hairy skin. Further to that, the skin is made up of different layers. You have the uppermost layer, which is the epidermis. The middle layer is the dermis, and the most inner layer is called the hypodermis. The skin is an important part of our body as it plays a huge role in forming a protective barrier between the insides of our body, which has important glands, organs that allow us to function in an optimal manner. In this case, this can act as a protective barrier and also prevents our bodily fluids from evaporation. What is not so obvious is how the skin provides us with the ability to make direct contact with the world. The best way to exemplify this is by putting yourself in a really dark room. In this scenario, we will use our ability to make direct contact to navigate our environment. This is commonly seen in rats, which are used to navigating in the dark using their whiskers. The presence of the mechanoreceptors in the skin allows us to transduce signals when we make contact with our environment. These receptors, as noted in its name, are activated by the onset of mechanical pressure. This deforms the capsule surrounding the nerve endings, and any changes to the capsule allows for an action potential to be generated in the nerve endings. This relays information towards the spinal cord and eventually reaching the brain. Our body can express 5 main mechanoreceptors involved in the somatosensory system. The last one on this list is not as well known as the 4 above it. For the purpose of this lecture, our focus will be on the first 4 on the list. The 5 mechanoreceptors are the Pacinian corpuscles, Ruffini's endings, Meissner's corpuscles, Merkel's discs, and cross-end bulbs. The mechanoreceptors that we discussed in the last slide collectively play a role in identifying the properties of a stimuli. For instance, mechanoreceptors have different receptive fields. Receptive fields are defined as the region of space which the presence of a stimulus will cause the firing of that neuron. Receptors can either have small or large receptive field size. In the diagram noted below, you can see the Meissner's corpuscle has a small receptive field size, while the Pacinian corpuscle has a large receptive field size. The signals that you get from different mechanoreceptors due to their different receptive field size can factor into our perception of what the stimulus is. For example, here is the concept of the two-point discrimination. The two-point discrimination is our ability to discern two close points on a small area of the skin. Hands and palms have the greatest sensitivity, while the area in our backs have the least sensitivity in the two-point discrimination. The next one is called adaptation. Adaptation is defined as a change over time in the responsiveness of the neuron due to a stimulus. Similar to receptive field size, mechanoreceptors have different adaptation rates. As you can see in the diagram below, Meissner's corpuscle and Pacinian corpuscle both have rapid adaptation to a stimulus, while Merkel's discs and Ruffini's endings have slower adaptation rates. What you can also see in the diagram below is what the difference between the Meissner's and Pacinian corpuscles are. In this case, they have different receptive field size. So although both are rapidly adapting to a stimulus, they would also have different receptive field size, which indicates their unique ability to contribute to our perception of a stimulus. Once action potentials are generated from the receptors, these signals are carried by primary afferent axons that innervate the receptors. Primary afferent axons are classified into four types. You have the A-alpha fibers, A-beta fibers, A-delta fibers, and C fibers. For the purpose of this lecture, we will go through the latter three fibers, which play a role in the perception of both touch and pain. What you can notice from these fibers is that they differ in the thickness of their axons, which indicates that these fibers have different speed in transmitting signals to the brain. In this case, A-beta fibers would be transmitting signals faster than A-delta and C fibers. The C fiber being unmyelinated indicates that this transmits signals the slowest. The primary afferent axon that carry touch sensation is the A-beta fiber. This fiber extends towards the spinal cord and enters it through the dorsal roots. From here, it ascends up the spinal cord and signals are relayed to the cortex. Depending on where the stimulus is, touching the primary afferent axon can enter the spinal cord in 30 spinal segments. This is mainly divided into four main divisions. You've got the cervical, thoracic, lumbar, and sacral. Within the cervical division, you have 8 spinal segments. In the thoracic division, you've got 12 spinal segments. The lumbar division having 5 spinal segments, and the sacral region having another 5 spinal segments. The way axons enter the spinal cord is dependent upon the dermatomes. A dermatome is the area of the skin innervated by a single spinal nerve. As you can see in the diagram below, each spinal nerve segment innervates a specific region of the body. Looking at this from upright position, the innervation is not obvious. However, if you consider or quadrupedal ancestry, you can see how these dermatomes are arranged. Shingles is a disorder that makes use of dermatomes. In this case, this is an infection that affects one or multiple dorsal nerves. It is associated with heightened excitability of neurons that can lead to the perception of pain, either with a stabbing or burning sensation. I mentioned dermatomes earlier since this also leads to the area of the skin associated with the infected dorsal nerves, having a distinct rash and redness look to it. When signals reach the spinal cord, they ascend the brain through the dorsal column lemniscal pathway. This only accounts for sensations felt from the neck down to the rest of the body. If you have touch sensations perceived in your head and face, this does not enter the spinal cord as the area is innervated by the cranial nerves. The cranial nerves will carry information to the brain using the trigeminal pathway. With the dorsal column lemniscal pathway, the pathway starts as primary afferent axons enter the spinal cord in the dorsal roots. From here, these fibers ascend the spinal cord ipsilaterally from where the stimulus was felt on the skin. The afferent axon will synapse on the dorsal column nuclei in the medulla, which has second-order neurons that distributes information to the ventral posterior nucleus in the thalamus. The information is then relayed to the primary somatosensory cortex. The trigeminal pathway, on the other hand, involves transduction of signals from the receptors to the cranial nerves. The primary one being trigeminal nerve, which is also known as cranial nerve number 5. As noted earlier, this does not go to the spinal cord, but will directly synapse to the principal sensory trigeminal nucleus in the pons. From here, axons will project to the ventral posterior nucleus in the thalamus, which will relay signals to the primary somatosensory cortex. In addition to the trigeminal nerve, it is also important to note that within the ear's nasal areas and pharynx, you have other cranial nerves that have the capacity to carry touch sensations to the brain. In this case, you have the facial nerve, the glossopharyngeal nerve, and the vagus nerve. The somatosensory cortex is the main area where complex somatosensory processing occurs. This is located in the parietal lobe. This is referred to as the Brodmann's area, or S1. The surrounding structures are also involved in processing somatosensory information. In this case, you have 3A, Area 1, and Area 2 located in the postcentral gyrus. You also have Area 5 and Area 7, which are located in the posterior parietal lobe. If you remember back to the dorsal column lemniscal pathway, it indicates that the ventral posterior nucleus will relay information received from the medulla into the primary somatosensory cortex. This area of the brain has been shown to be responsive to somatosensory stimuli, which is, in this case, is the activation of the mechanoreceptors on the skin. Furthermore, studies have shown that if you apply a lesion in this area, you can impact the perception of a somatic sensation. Conversely, if you apply electrical stimulation in this area, It can lead to experiencing somatic sensation depending on which part of the Brodmann's area is stimulated. Area 1 and Area 2 receive signals from the primary somatosensory cortex, and each have their own contribution to the perception of somatic sensation. Area 1 has been shown to be involved in processing texture information, while Area 2 has been involved in processing size and shape information associated with somatic sensation. Lesions in this area was shown to impair these functions from these two areas. Now, the next section in the lecture is looking at the concept of somatotopy. Cortical somatotopy is defined as the mapping of the body's surface sensations into the brain structure. Mapping is done through the application of electrical stimulation, which can elicit somatic sensations around the body. In this case, you can determine which part of the primary somatosensory cortex that is involved in the processing of somatic sensation received from different areas of the body. Mapping of the function of the primary somatosensory cortex has resulted in the homunculus seen in the diagram on this slide. This homunculus is not to scale. However, this is a good indication to see which areas of the body is important in detecting somatic sensation. From here, you can see that the lips, tongue, fingers, and hands have greater devotion in the primary somatosensory cortex compared to the rest of the body. Going back to the example of navigating through the dark, the hands and fingers are useful in this scenario. Furthermore, when tasting food, we use our lips and tongue to taste the food. This involves the interaction of both the gustatory system and the somatosensory system. The posterior parietal cortex play a crucial role in somatic sensation, visual stimuli, and movement planning. It is the area of the brain where all of these input converge to make sense of what we perceive in our environment. Diseases in the somatosensory cortex is mainly attributed to the damage in the posterior parietal lobe. Agnosia is a disorder where you are unable to recognize objects using one or more senses. More specifically to somatic sensation, this is referred to as stereoagnosia. As an example, if you have keys in your pocket and you try to identify this object using your somatic sensation, you won't be able to recognize this when you have stereoagnosia. The other condition associated with damage in the posterior parietal cortex is called the neglect syndrome. The neglect syndrome is a neurological disorder characterized by reduced awareness of stimuli on one side of the space. An example here is the case of the man who fell out of his own bed. This case started with a man who was admitted for exhibiting signs of a lazy left leg. After falling asleep, the man awoke and found what he thought was a cadaver's leg in bed with him. Of course, when you experience something like this, you would immediately feel disgust, and this man tried to physically remove the leg from his bed, only to throw himself out of his own bed. This case is an example of the neglect syndrome. More specifically, this is referred to as the parietal ataxic hemiparesis. To sum up the first half of the lecture, the sensory systems exhibit similar organization and function. In this case, you have a starting point at the receptor level where stimuli is detected. Information is then transduced to an action potential, and this is relayed to the cortex for processing. For somatic sensory information, this is sent to the cortex via two pathways. You've got dorsal column lemniscal pathway, and then you also have the trigeminal pathway. Processing in the primary cortex will eventually lead to convergence of information in the posterior parietal cortex, which contribute to our perception of the environment. The second half of the lecture looks at the pain system, which is another part of the somatosensory system. Just to provide you with a quick introduction, pain is the feeling of or perception of irritating, sore, stinging, aching, throbbing, miserable, or unbearable sensations arising from a part of the body. It is important to note that the sensory processes associated with pain information is referred to as nociception. Unlike mechanoreceptors that are responsible for transducing touch sensations, nociceptive receptors are free, unbranching, unmyelinated nerve endings. Nociception is a defensive mechanism which allows the host to determine the onset of risk to the body. Whether you have a needle piercing your finger to feeling a specific discomfort in your leg while running, nociception is triggered when you have tissue damage in the body, which can be from strong mechanical stimulation, exposure to extreme heat or temperature, oxygen deprivation, and having chemical applied to your skin. The resulting damage to cells leads to the release of substances that open up the ion channel in the free unmyelinated nerve endings. This leads to degeneration of an action potential. When signals are generated from the receptors, these action potentials are carried by primary afferent axons. In this case, you have a delta fiber and a C fiber. A delta fiber is larger and coated with myelin. Nociceptive information carried on this axon travel quickly to the brain and has been associated with the perception of fast pain. A delta fibers are known to release glutamate at the synapse with spinal neurons. The next primary afferent axon that I alluded to earlier is the C fiber. Compared to a delta fiber, this axon is a lot smaller in width and is due to the fact that this is unmyelinated. Because of this, the signals carried on this axon travel slower and has been referred to as the slow pain. It was determined that the neurotransmitter released in the synapse of this axon are glutamate and substance P. The distinction between the fast and slow pain is important in our perception of the whole experience of pain. Imagine yourself pricking your finger with a needle. The experience of pain can be divided into two parts: the initial sharp pain and the lingering pain associated with the resulting wound. The initial sharp pain is associated with fast pain, and the lingering painful sensation is associated with the slow pain. Both of these carry nociceptive information to the brain, but provides us with the context of what the pain is associated with. Like the somatic system, the primary afferent axon that carry information to the spinal cord is done through the dorsal roots. The difference is associated with how information is carried up to the brain. As the information enters the spinal cord, the axon synapses to another set of neurons that crosses to the other side and from here ascends to the brain. This slide is a summary showing you the differences between the touch and pain systems. From the diagram that you see in your right-hand side, these two systems are segregated from one another. Firstly, the receptors are different from one another. Mechanoreceptors are capsulated, while nociceptors are free branching unmyelinated nerve endings. Secondly, the primary afferent axons differ from one another. A beta, the primary afferent axon for touch sensation, has the largest diameter compared to A delta and the C fiber. And lastly, as you can see in the diagram, the information to the spinal cord differs in how it sends the brain. In this case, pain information ascends ipsilaterally, while nociceptive information ascends contralaterally. The name of the pathway that carries nociceptive information is called the spinothalamic pathway. These differences are depicted in the Brown-Séquard syndrome. This syndrome is characterized by constellation of sensory and motor signs following damage to one side of the spinal cord. In this case, when you have damage on the left side of the spinal cord, this leads to a loss of pain sensation in the right side and a loss of touch sensation on the left side. Like touch sensation, pain perception in the head and face is carried separately from spinothalamic tract. In this case, it is carried through the trigeminal pain pathway. This synapse first on second-order neurons in the spinal trigeminal nucleus of the brainstem, and the information ascends to the thalamus in the trigeminal lemniscus. Axons that carry nociceptive information synapse at larger regions in the thalamus. In this case, it ascends information through the ventral posterior nucleus and the intralaminar nuclei. What's amazing about our body is that we have the ability to regulate pain sensation. Regulation of pain sensation can be divided into two parts: the afferent regulation and the descending regulation. The afferent regulation of pain is represented by the gate theory of pain presented by Melzack and Wall. In this theory, it was proposed that if you are experiencing pain in one part of the body, activation of the somatic sensation in the same area can decrease the perception of pain. For example, hitting your head on something solid and hard as you stand up will often result in you rubbing that area with your hands and fingers. It was noted that when touch information is carried by the primary afferent axon, which enters the spinal cord through the dorsal roots, this can also activate existing interneurons that inhibit the transmission of nociceptive information to the brain, which forms the basis of the ascending regulation of pain. Descending regulation of pain, on the other hand, is associated with the activation of the periaqueductal gray area, associated with binding of endogenous opiates. The periaqueductal gray area sends information down to the spinal cord, inhibiting the transmission of nociceptive information to the brain. The next slide is showing you the organization of neurons in the pain system. In this case, neurons that carry nociceptive information is divided into three sections. We have the first-order neurons represented by the primary afferent axons that carry information from the receptor to the spinal cord. Then you have the second-order neurons that are represented by neurons that receives input from primary afferent axons in the spinal cord. And lastly, you've got the third order neurons that receives input in the thalamus and carry information to the primary somatosensory cortex. When information is relayed through the brain, it goes through two pathways, the paleospinothalamic tract and the neospinothalamic tract. This paleospinothalamic tract leads to the reticular activating system, which results in the arousal, change in mood, and attention. On the other hand, the neospinothalamic tract leads to the thalamus and the parietal cortex. This allows for localization and the identification of pain. The periaqueductal gray region, as discussed earlier, is part of the descending regulation of pain. These collection of neurons has receptors that bind specifically to opioids generated endogenously. Synthetic opioids can also bind to these neurons when introduced in the body. This can result in an analgesic effect, and as the name suggests, activation of this area leads to nerve impulses being sent down from the brain to inhibit neurons that carry pain information to the brain. Now, pain can be divided into different types, mainly by the source of the pain or the tissues involved. Firstly, you've got cutaneous pain. Cutaneous pain is associated with damage in the skin and superficial tissues. The second one is deep somatic pain. This is associated with damage in the blood vessels, ligaments, and bones. The third one on the list is the visceral pain. This is involved in damage to internal organs, for example, the heart, intestines, and the lungs. You also have the concept of the referred pain. Referred pain is defined as pain that is felt at a site distant from the site of origin. This is based on the fact that cutaneous and visceral afferent axons ascends through the spinal cord using the same route. Adjacent axons undergo crosstalk, which allows for substantial mixing of information. Therefore, when this information reaches the brain, the pain can be perceived distant from the site of origin. An example that I can give you here is the onset of angina. Angina is caused by the deprivation of oxygen in the heart tissues. This can lead to activation of nociceptors, which send signals to the brain. In this situation, the primary afferent axons innervating the heart ascend the spinal cord adjacent to afferent axons innervating the upper left arm. Therefore, pain can be localized by the patient to both the upper chest wall and also the left arm. The final kind of pain that I will be discussing is neuropathic pain. This pain originates from damage to nerve tissues. This can be caused by putting pressure on the nerve, having physical or chemical injury to the neuron, onset of infection in the neuron, ischemia, and inflammation on the neuron. For the purpose of this lecture, I will go through 4 neuropathic syndromes, namely trigeminal neuralgia, postherpetic neuralgia, complex regional pain syndrome, and the phantom limb pain. The first of the neuropathic syndrome is the trigeminal neuralgia. This disorder is characterized by the onset of facial tics, grimaces, and stabbing. This has been associated with damage to the trigeminal nerve, also known as cranial nerve number 5. Patients who have this disorder have decreased quality of life due to excruciating pain from facial movements. For example, if you're eating. In some cases, these symptoms can also occur without stimulation. The main treatment for this disorder is the use of anticonvulsants, for example, carbamazepine. The other option is to opt for surgery or gamma surgery. Example of a surgery is called the microvascular decompression. This procedure involves relocating or removing blood vessels that are in contact with the trigeminal root to stop the nerve from malfunctioning. The incision is made usually just behind the ear. A hole is made in the skull, and surgeons will move any arteries that are in contact with the trigeminal nerve. A soft cushion is usually placed between the nerve and arteries to ensure that the pressure on the nerve is prevented. Microvascular decompression can eliminate or reduce pain. However, this can also reoccur in some patients. Like any other surgery, this procedure will come with risks, including decreased hearing, facial weaknesses, facial numbness, stroke, or other complications. The other method is called the gamma knife surgery. This is where a surgeon will take a focused dose of radiation to the root of your trigeminal nerve. This leads to damaging the trigeminal nerve and reduce or eliminate the pain felt in trigeminal neuralgia. The effect of this surgery is gradual, where the relief does not occur immediately and will take up to a month for results to be seen. The next syndrome is called the postherpetic neuralgia, or shingles. This is caused by recurrent infection by the varicella virus or the chickenpox. This leads to injury to the peripheral nerve, leading to inflammation, hemorrhage, necrosis, and neuronal loss. This causes spontaneous discharge of nociceptive information, which is then felt or perceived by the brain. Treatment of shingles involves the use of topical analgesics, such as lidocaine, and tricyclic antidepressants, such as amitriptyline. The next syndrome is called the complex regional pain syndrome. The exact nature of this syndrome is obscure, but the sympathetic nervous system was shown to be associated with this disorder. Complex regional pain syndrome is defined as chronic pain condition that most often affects one limb, usually after an injury. This can be an arm, leg, hand, or foot. This is characterized by prolonged or excessive pain and changes in skin color, temperature, or swelling in the affected area. Complex regional pain syndrome is characterized into two types. You have type 1, and then you also have type 2. Type 1 is when individuals are diagnosed with complex regional pain syndrome without a confirmed nerve injury. This type 2 is when individuals have been associated and confirmed with nerve injury. Other symptoms of complex regional pain syndrome involves intense and burning sensation long term. Treatment involves use of adjuvant analgesics. Furthermore, surgery is also an option here through sympathectomy. Sympathectomy is when you're cutting a sympathetic nerve to alleviate the symptoms of the syndrome. Finally, we have the phantom limb. Phantom limb is a syndrome that occurs after a limb or a part of a limb is amputated. This leads to the feeling of tingling, heat or cold, heaviness, burning, or shooting pain. The pathophysiology involved in phantom limb includes tangling of regenerated neurons at the site of amputation. You also have the spinal cord neurons that can fire spontaneously. And lastly, you also have the concept of brain plasticity. Treatment of phantom limb involves use of relaxation techniques, hypnosis, and use of sympathetic blocks. And with this, we have reached the conclusion of the lecture. Should you have any questions, feel free to contact me via my email. Thanks, everyone.